Sreenivas, consultant neurologist from Rajahmundry, Andhra Pradesh, India. My mail ID is sreeklpm@gmail.com, and I am also the medical author of the book Focused Neurology, which is available online. So today we'll be talking about the fundamental concepts of neurologic examination, the importance of neurologic examination in neurologic diagnosis. So when we start off the neurologic evaluation, initially we begin to analyze the general physical examination relative to neurologic examinations. So we start off with vital signs. If there is hypertension, we think of compensatory phase of ischemic stroke, Cushing's reflex, which is a triad of hypertension, bradycardia and irregular breathing, subarachnoid hemorrhage. If a person has orthostatic hypotension, we think of syncope like diabetic neuropathy, multiple system atrophy and antihypertensive therapy. Pulse. If a person has got bradycardia, we think of Cushing's reflex, whereas if a person has got bounding pulse, we think of aortic regurgitation and hyperthyroidism. If a person has got a slow, small pulse, we think of aortic stenosis. If a person has got an irregular pulse, we think of atrial fibrillation. This is going to be a very important clinical finding because atrial fibrillation is one of the important and common causes for embolic strokes. Arrhythmias, either brady or tachyarrhythmias, can cause cerebral hypoperfusion. Then we look at the general appearance. If there is weight loss, we think of hyperthyroidism. If a person has got spastic hemiparesis, that is flexion of the upper limb and the extension of the lower limb, because of the spasticity, we call that spastic hemiparesis. We see in cerebrovascular accidents in stroke patients. This is known as circumduction gait. The weakness is there in the extensors of the upper limb and the flexors of the lower limb, but the tone gets increased as spasticity is seen in the flexors of the upper limb and extensors of the lower limb, and therefore they flex the upper limbs like this, extend the lower limbs. Since they need to clear off the ground, they encircle the lower limbs and then walk. This is known as the characteristic circumduction gait, which we see in CVA patients. If a person has got a flexed posture and no arm swing, short shuffling gait, expressionless face, we think of Parkinson's disease. Myopathies. If muscles are weak, persons will have lordosis, protrusion of the abdomen. Because of the gluteus medius weakness, they cannot flex the pelvis, they cannot fix the pelvis when they walk, so there is a waddling gait, and there is hypertrophy of the calves like Duchenne's muscular dystrophy. If a person has got hereditary neuropathy, a long-standing neuropathy will cause unequal weakness of paravertebral muscles resulting in scoliosis, or unequal weakness of the foot muscles resulting in pes cavus. A person may have claw hand due to ulnar neuropathy, and radial neuropathy because of the wrist extensor weakness produces a wrist drop, is seen in persons who drink a lot and assume awkward postures after a bout of alcohol on Saturdays, otherwise known as Saturday night palsy. If the common peroneal nerve is involved, dorsiflexors are the weak, so they will have foot drop, and to clear off the ground they have to take high steps. So these are all the important findings which we see on general appearance pertaining to neurologic examination. We have to look at the head. If there is an abnormal head tilt, it could be cervical dystonia or superior oblique palsy. Superior oblique causes intorsion of the eye, and therefore when the intorsion of the eye is deficient, they try to compensate by turning the head to the opposite side, which is known as head tilt sign, otherwise known as Belshazzar's sign. If there is a big size head, we think of hydrocephalus, and if there is an abnormally shaped skull, it could be premature closure of cranial sutures. If there is a history of head injury, we need to look at the battle sign and raccoon sign. Battle sign is ecchymosis over the mastoid because of the basilar skull fracture, and raccoon sign is because of the ecchymosis around the eye. Continuing with the head, if a person has got raised ICP in children, there is bulging of the fontanelle and suture separation, because sutures have not yet formed, and therefore if there is raised ICT, the sutures separate. There could be skull defect leading on to meningocele and encephalocele. These are known as neural tube defects. It can occur at the level of the spinal cord, which we call as spina bifida. At the level of the skull, we call it as meningocele or encephalocele. If meninges protrude out or if the brain protrudes out, we call it as encephalocele. It is because of the neural tube defect. The anterior port does not close well, we develop cranial defects. And if the posterior port does not close well, we develop spinal cord defects. Auscultation, we have to look at the ocular bruit for any malformations or stenosis. Carotid bruit for carotid stenosis. If there is a hydrocephalus, massive head prior to suture closure in children, there could be frontal bossing and transillumination. McEwan sign, a sign to detect hydrocephalus and brain abscess. Percussion, tapping on the skull at a particular spot near the junction of the frontal, temporal and parietal bones yields an unusually resonant sound in the presence of hydrocephalus or brain abscess. So what are the important physical examination findings of face related to neurologic examination? We need to look at if there is any port wine angioma, which is suggestive of Sturge-Weber syndrome. We see characteristic facies in myotonic dystrophy like absence of sternocleidomastoid, balding of the head. If there is a procurus or surprise sign, we have to suspect progressive supranuclear palsy, and if there is an expressionless mask-like faces, we have to suspect Parkinson's disease. Then we look at the eyes. If there is telangiectasia, we think of ataxia telangiectasias. If there is exophthalmos, it could be hyperthyroidism. If there are vesicles, it could be herpes zoster ophthalmicus. If there is arcus senilis, it could be atherosclerosis. Wilson's disease will produce KF ring on Descemet's membrane. Ear. If there is blood accumulation or hemotympanum, we have to suspect temporal bone fracture or basilar skull fracture. If there are vesicles, we have to suspect herpes zoster infection. Then we have to look at the nose, mouth and throat. If there is saddle nose, we suspect congenital syphilis. If because of head injury, there could be CSF rhinorrhea. How do we differentiate CSF rhinorrhea from mucus secretion of the nose? If there is sugar in the fluid, it is CSF. So CSF rhinorrhea could be because of head injury. There could be a big tongue macroglossia because of hypothyroidism. We can see tongue bites in seizures. Seizures, they have tongue bites. In neuroacanthocytosis and Leschnian syndrome, where there is self-mutilation, there could be tongue bites. If a person has got notched teeth, which is known as Hutchinson's teeth, we have to suspect congenital syphilis. If there is trismus, it could be tetanus or polymyositis. If there are mucosal ulcerations, it could be Behçet's disease. Then the general physical examination related to neurologic examination, the neck. If there is neck swelling, it could be thyroid swelling. If there is neck stiffness or rigidity, it could be meningitis or subarachnoid hemorrhage. Because of the infection and inflammation or irritation of the meninges, there will be neck rigidity. If there is a short neck, we have to suspect craniovertebral junction CVJ anomaly like Klippel-Feil syndrome, which is nothing but a bone disorder characterized by the abnormal joining, fusion of two or more spinal bones in the neck cervical vertebrae. The vertebral fusion is present from birth. Then neck, we have to check the Lehermet sign. A flexion of the neck causes electric shocks like sensation going down the spine because of the posterior column involvement like multiple sclerosis, or in aged people it could be cervical spondylosis. We have to palpate the carotid arteries and see the carotid stenosis and auscultation also for bruit. The respiratory system. When there is a raised intracranial pressure, there would be Cushing's reflex, which is nothing but hypertension, bradycardia and irregular respiration. So if there is irregular respiration, it could be Cushing's reflex because of the raised ICP. The respiratory failure and the failure of the muscles of the respiration, then we have to suspect Guillain-Barré syndrome or myasthenia gravis or amyotrophic lateral sclerosis. How do we check the respiratory failure and impending disastrous respiratory failure leading on to ventilatory support at the bedside every day? We ask them to perform single breath count. If on day 1 it is 25 and if it is on day 2 it is 20, on day 3 it is 15, that means a single breath count is coming down and is in for trouble. So respiratory failure at the bedside can be assessed by single breath count. Then we check out the respiratory pattern. This is very interesting and exciting. We can place the lesion by looking at the respiratory pattern. Imagine there's an hematoma in the brain going and compressing from the cerebral cortex to the midbrain pons and medulla oblongata. As it descends down or the herniation descends, we see the various manifestations. Suppose if the cerebral cortex is involved, it is chain strokes respiration. Waxing, then stop, waning, then waxing and then waning. So waxing, waning, it is chain strokes respiration. When it descends to the midbrain level, they'll have central neurogenic hyperventilation. That means they keep on hyperventilating very fast. When it comes to the pons, it becomes apneustic breathing. They take a deep inspiration, pause and then expire. Deep inspiration, pause and then expire. And when it comes to the medulla oblongata, it becomes Biot's breathing. Totally irregular pattern. Irregular breathing. Biot's breathing. So by just looking at the respiratory pattern, we can place the lesion where the herniation is slowly descending and affecting the different parts of the neuro axis. If the cerebral cortex, it will be chain strokes respiration. If it is midbrain, it will be central neurogenic hyperventilation. If it is pons, it's going to be apneustic breathing. If it is medulla oblongata, it's going to be the Biot's breathing. Then we have to check out on the cardiovascular system. Hypertension, atherosclerosis, endocarditis, arrhythmias, valvular diseases, all the above produces neurologic complications. So we should always check out on hypertension, atherosclerosis, endocarditis, arrhythmias and valvular disorders. Abdomen. There could be Gray Turner's sign, that is ecchymosis of the flank. It may be due to lumbosacral plexopathy due to retroperitoneal hematoma, or there could be hepatomegaly, which could be because of cirrhosis or carcinoma giving rise to hepatic encephalopathy, or there could be splenomegaly, which we see in lot of storage disorders, inherited metabolic disorders. We have to always check out on the genitalia and rectum. We have to do rectal examination and look for the sphincter tone, especially if there is myelopathy, cauda equina or conus medullaris. If S2, S3, S4 are involved, then the anal tone becomes very lax. If there is Fabry's disease, there could be angiomas on the scrotum. Then we have to look at the lymph nodes. If there is lymphadenopathy, it could be phenytoin, it could be HIV, it could be lymphoma, or it could be infectious mononucleosis. Then we have to look out on the spine. If there is marked kyphosis, what we call as gibbous, it is suggestive of tuberculosis. If there is lumbar lordosis, protrusion of the abdomen, we have to suspect muscular dystrophy. If there is scoliosis, it could be Friedreich's ataxia or syringomyelia. If there is a dimple of the skin tag, unusual hair growth of the sacrum, then we have to suspect spinal dystrophic state like tethered cord syndrome. It is a neural tube defect wherein the posterior pore does not close at the appropriate timing of the fetus, and therefore we have these manifestations. Then we have to look at the extremities. There could be Charcot's joints, that is painless arthropathy when the joint is deafferented. There could be arthropathy because of connective tissue disease. Decreased peripheral pulses may be there because of atherosclerosis, or there could be hypermobile joints like Marfan syndrome and Ehlers-Danlos syndrome. There could be palmar erythema, which is suggestive of alcohol abuse. So these are all the findings we have to look at the extremities. Then we have to look at the hair and nail. If there is alopecia and balding, as I said in my earlier discussion, it could be myotonic dystrophy along with the absence of the sternocleidomastoid muscle. If there are Mees lines, that is transverse discoloration of nails, it could be arsenic poisoning. Clubbing of the nails could be bronchogenic carcinoma with metastatic and non-metastatic manifestations, and abnormal nail capillaries, it could be dermatomyositis. Skin is very, very important when we examine a neurological disordered patient. When we do a neurologic evaluation, examination of skin is very, very important because skin and nervous system both originate from the ectoderm, and therefore when there are nervous system abnormalities, there could be abnormalities on the skin also. So just by looking at the skin and neurocutaneous markers, we will be able to diagnose a lot of neurological disordered conditions. If there is painless, poorly healing skin ulcers, it could be syringomyelia, because syringomyelia affects the center of the spinal cord, wherein the crossing spinothalamic fibers get affected, but it spares the posterior column. So pain is affected, but the touch sensation is spared. Since the pain is lost, they will not be able to appreciate pain, and it will result in painless, poorly healing skin ulcers. Again, hereditary sensory neuropathy also can lead on to painless, poorly healing skin lesions. If there is spider angioma, we have to suspect alcohol abuse. If there is purpura in a person who's got fever, neck stiffness, altered sensorium, we have to check out the meningococcemia. If there is erythema chronicum migrans, it could be Lyme's disease. If there is livedo reticularis in a person who's got recurrent abortions, we have to suspect antiphospholipid syndromes. If there is greasy and seborrheic skin, it could be Parkinson's disease. If there are vesicular lesions, it could be herpes zoster. And we see a lot of characteristic lesions of dermatomyositis. The dry skin indicates Refsum's disease, and if there are angiomatosis, it could be Fabry's disease. Right. Now, having made a preliminary general physical examination related to neurological conditions, now we will see the neurological examination per se. The neurologic examination begins with assessment of mental status, the cranial nerves, the motor system, reflexes, sensory system, coordination and gait. The mental status examination, we look for the level of consciousness, whether the person is conscious or not. If the person is drowsy, we give painful stimuli and see whether he is able to withdraw the limbs. So we have to describe the entire findings, like what is the reaction of the person when we pinch, instead of labeling him stuporous or any other state which may cause confusion. So it is better to describe the procedure and the findings which we have elicited and the reaction which the patient has given. Orientation to time, place and person. Orientation to time is the first to be affected. Then we look at the speech, dysarthria. For example, a person may have problems with the usage of the lips or the tongue or the palate. The palate is supplied by the 10th nerve. So if the 10th nerve is affected, they cannot use the palate. If 12th nerve is affected, 12th nerve supplies us the tongue, they cannot use tongue well. If 7th nerve gets affected, they cannot use the lips well. So if there is a 7th nerve palsy, they cannot use lips well. So labial component gets affected. For example, they can't say pa, because pa needs the use of lips. If the 12th nerve is affected, they cannot use tongue. So lingual component gets affected. They cannot pronounce ta, which needs the usage of tongue. If 10th nerve gets affected, the palate gets affected, the palatal component gets affected. They can't say ka, which needs the usage of palate. So by looking at the usage and their speech, usage of lips, tongue and palate and the speech, the dysarthria, we can make out whether it is the 10th, 7th or 12th nerve are affected, or cerebellum. Cerebellum causes a scanning speech. For example, If a person wants to say pataka, they say pa tha ka, they scan. So scanning speech is seen in cerebellar disorders. So we have to look on the speech, check out on the speech and the language. Language is a cortical function. The two important epicenters for language are the vernix area and the Broca's area. Vernix area is for understanding the speech. Arcuate fasciculus is for the transmission of the speech from the vernix to the Broca's area. Broca's area is the area for fluency. Generally, a person is able to speak 100 to 115 words per minute. If a person is just able to speak 10 to 15 words per minute, or even less than 10 or less than 7 words, that means it is a non-fluent aphasia, which indicates Broca's aphasia. He can understand but he can't speak. Whereas if it is vernix aphasia, he cannot understand but he keeps on speaking a fluent but nonsense speech. If arcuate fasciculus gets affected, repetition is affected. If it is Broca's aphasia, that means the superior division of the middle cerebral artery is affected. If it is vernix area, that means inferior division of the middle cerebral artery is affected. If both Broca's and vernix are affected, it is a global aphasia. That means the stem of the middle cerebral artery is affected. And the language is affected, aphasia is seen in right-handed persons, because more than 90% of the right-handers, the speech centers are on the left side. Only 10% is on the right side. So we generally see aphasia in a right-handed person with right hemiplegia. A right-handed person with left hemiplegia, we generally don't see aphasia, and their speech, their language is good. Memory is very important, because memory goes to frontal lobe for short-term memory, then it goes to the hippocampus, where the immediate memory is converted to short-term memory, and then the long-term memory goes to the temporal and the lateral cortex. So the immediate memory goes to the frontal lobe. So we have to test immediate memory, that is the short-term memory, or the intermediate memory, or the long-term memory. The immediate memory, we give 7 digits forwards and 5 digits backwards, or we give them 3 unrelated articles and ask them to repeat immediately. That is the immediate memory. The intermediate memory, we ask the person to repeat the 3 unrelated articles after 5 to 10 minutes. So this indicates that the hippocampus is affected. If hippocampus is affected, person loses the intermediate memory. Hippocampus is also the GPS of the human beings. It is important for the spatial orientation. And then finally it forms engrams and goes to the long-term memory. We test it by asking the name of the presidents or prime ministers. So memory is a very important component. We have to test the immediate memory, intermediate memory, and long-term memory. Memory can get affected in various disorders like Alzheimer's dementia, or multi-infarct dementia, or dementia with Lewy bodies, or Pick's disease. So there are a lot of causes of memory loss and dementia. But what we are interested is to find out treatable cause of dementia like hypothyroidism, vitamin deficiencies, normal pressure hydrocephalus, wherein we can treat the person. Then we have to check out on the fund of information according to his educational status. Ask about all the information or all the data which he knows. Just inquire about it and find out and relate it according to his educational status. Then we look at the insight and judgment. We can give examples like what would you do if the house is on fire, or what would you do if you find an envelope on a road, and then see how his reaction is. If it is appropriate to the situation, that means his insight and judgment are good. Then we check out on the abstract thought, the similarities between various objects like apples and oranges belongs to the category of fruit, or all the words starting with the letter A. So how he is able to relate all these? It is a test for the abstract thought. Calculation ability, depending upon his education status, we give a simple forms of calculation like subtract 9 from say 90, and again subtract 9 from 81, and just see how he goes. So these are all the important 8 points of mental status examination. After mental status examination, we check out on the cranial nerves. But before I go into the details of the cranial nerve examination, let me simplify the cranial nerves, where they are located in the brainstem, so that it will be very useful for a student or a consultant to localize the lesion. So we have 12 pairs of cranial nerves. This is known as rule of 4. There are 4 nerves in the midbrain and above, 4 nerves in the pons, and 4 nerves in the medulla oblongata. So 1, 2 are above midbrain, and 3 and 4 are in the midbrain. 5, 6, 7, 8 are in the pons, and 9, 10, 11, 12 are in the medulla oblongata. So this is known as rule of 4. I repeat, there are 4 cranial nerves in midbrain and above. That is 1, 2 is above midbrain, 3, 4 is in the midbrain. There are 4 cranial nerves in the pons, 5, 6, 7, 8, and 4 cranial nerves in the medulla oblongata, 9, 10, 11, 12. Now we should have an easy way of remembering what cranial nerves are present in the midline and what cranial nerves are present laterally. The cranial nerves which divide 12 into equal parts are placed in the center, in the midline. The cranial nerves which cannot divide 12 into equal parts are placed laterally. For example, when we take third and fourth nerves in the midbrain, they divide 12 into equal parts. 12 by 3 is 4. 12 by 4 is 3. So since 3 and 4 divide 12 into equal parts, 3 and 4 are in the midbrain. When we take 5, 6, 7, 8, 5, 7, 8 cranial nerves cannot divide 12 into equal parts. So 5, 7, 8 are placed laterally. But the sixth nerve can divide 12 into 2 equal parts. So sixth nerve is placed in the midline of the pons. Then when we come to the 9, 10, 11, 12 cranial nerves, only 12 can divide 12 into an equal part, that is 1 part. So 12 is placed in the center medially, and the rest 9, 10, 11 are placed laterally. So if we know this rule of 4 and the cranial nerves, how they divide 12 into equal parts or unequal parts, we can place where the cranial nerves are situated. So the cranial nerves which divide 12 into equal parts are situated medially, like 3, 4 in the midbrain, 6 in the pons, and 12 in the medulla oblongata. The rest of cranial nerves which cannot divide 12 into equal parts are placed laterally. Having had this brief exposure, now we'll see the cranial nerve examination. The olfactory nerve, we test smell by giving coffee powder or any stimulant, but not an irritating stimulant, because it can go and stimulate the trigeminal nerve like ammonia. So we give test like coffee powder for smell. It is generally useful only when there is a suspicion of inferior frontal lobe disease like meningioma or head injury, because head injury causes anosmia usually. So we can check out on the olfactory nerve in some cases where there is a suspicion of inferior frontal lobe like meningioma or head injury. Then we check out on the optic nerve. Optic nerve is tested by visual acuity. We give Snellen's chart and then we ask the person to see that particular letter in the chart. So we have a numerator and denominator. Denominator represents the normal persons who see that particular letter at that particular distance, and the numerator is the patient's condition. So visual acuity is the Snellen chart, which talks about his sharpness of the vision. Field of vision we test by confrontation. So we ask the patient to sit in front of us facing the examiner. The patient looks at the examiner's eyes, examiner looks at the patient's eyes. He brings the hand from the lateral to the medial part, and the patient should be able to tell exactly when the hand has appeared, and it should coincide with the examiner seeing the particular hand at the same time. So by plotting these fields, we can make out whether the person has got field defects, because this gives a lot of information. Some of the details we can check out clinical and even make a diagnosis. That is the joy of clinical neurology. For example, when we check on the confrontation field of vision, if a person has got bitemporal hemianopia, he is not able to see on the temporal sides, on the both sides, that means he's got pituitary tumor. So So we do not even have MRI or CT scan to diagnose. Just by checking field of vision and confrontation, we can say whether the person has got bitemporal hemianopia, and because of that, because of the pituitary tumor. And very important observation is ophthalmoscopy, looking at the optic fundus. This is the only place where we can look at the cranial nerve directly, the second cranial nerve, and this is the only place in the entire body where we can look at the vessels directly, whether the vessels are narrowed or whether there is any AV nipping or whether there is any absence of spontaneous venous pulsations which can indicate that the person has got papilledema. So always we should make it a point to look at the optic fundus, because it's the only place where we can look at the cranial nerve directly, that is second nerve, the papilla, the fundus, and this is the only place where we can visualize the vessels directly, looking at whether the vessels are compromised, are narrowed, or AV nipping, or absence of spontaneous venous pulsations. Papilledema indicates that there is a raised SOL, space occupying lesion, and there is impairment of the venous return because of the axonal constriction. Third nerve. The third nerve, if there is a lesion of the third nerve, it characteristically produces 4 Ds. Dilatation of the pupil, because the parasympathetic fibers run on the third nerve, and therefore the parasympathetic fibers are compromised, like posterior communicating artery aneurysm. The parasympathetic fibers get affected. Parasympathetic causes constriction of the pupil. Since the parasympathetic is affected, pupils can't constrict, there is dilatation of the pupil. Here is one more important point. If there is an ischemic lesion of the third nerve, it affects the center of the third nerve, and therefore the parasympathetic fibers are spared in an intrinsic pathology of the third nerve, like diabetes. That's why it is known as pupillary sparing third nerve. Another very important concept in terms of pupil is that after death we see that the pupils are dilated. Brain death or the death, we see the pupils are dilated. But the question is, pupil is supplied by both parasympathetic, which causes constriction of the pupil, and sympathetic, which causes the dilatation of the pupil. And therefore after death, when parasympathetic and sympathetic are affected, pupil should be in the mid position. But what we see in clinical practice is that pupil is dilated after the death. What is the mechanism? The mechanism is that though the parasympathetic and sympathetic supply the pupil, it is a parasympathetic which has got more action on the pupil than sympathetic, and therefore after the death it is a parasympathetic which gets affected more. Since parasympathetic causes constriction of the pupil, since it is affected more, there is a dilatation of the pupil. So the answer for why there is a dilatation of the pupil after death is that parasympathetic has got more control over the pupil than sympathetic. The other manifestations of the third nerve are the drooping of the eyelid. Because the levator palpebrae superior is affected, there will be drooping of the eyelid. Again here there is a catch. The levator palpebrae superior both are supplied with a single third cranial nerve nucleus in the midbrain, and therefore if it is a brainstem lesion like midbrain lesion, there will be ptosis of both sides. But if the radical, only the fascicle gets affected, there will be unilateral drooping of the eyelid. But if it's a brainstem pathology, both the levator palpebrae superior gets affected, there will be drooping of the eyelid. And the third nerve supplies all muscles except LR6, lateral rectus, supplied by 6th nerve, and superior oblique supplied by the 4th nerve. And since the third nerve is affected, 6th nerve, lateral rectus will overact, so there will be divergent squint, eyes will move away, they diverge, and because of that they will have double vision. So dilatation of the pupil, drooping of the eyelid, divergent squint, and diplopia. These 4 Ds suggest that it is a third cranial nerve involvement. The fourth cranial nerve. Fourth cranial nerve, it is superior oblique. Its action is intorsion of the eye. So the fourth nerve or superior oblique is affected, they cannot intort the eye. To compensate that, they turn the head towards the opposite side. It is known as the head tilt sign or Beltrovsky's sign. So if we see any person coming with a head tilt, we should always suspect Beltrovsky's sign or fourth nerve palsy and superior oblique involvement. The fifth nerve. Fifth nerve has got sensory component and the motor component. So the sensation which we test in the 3 territories: ophthalmic, forehead, maxillary, cheek, and mandibular chin. So we test the sensation. If the ophthalmic part gets affected, there could be pain also, like herpes zoster ophthalmicus, which affects the ophthalmic division of the trigeminal nerve. Whereas trigeminal neuralgia affects the maxillary and mandibular divisions of the fifth nerve. So ophthalmic division of the fifth nerve, we have to suspect herpes zoster ophthalmicus, maxillary and mandibular division, severe pain in the maxillary and mandibular divisions, we can suspect trigeminal neuralgia, especially in young patients. The motor component, we check on the jaw clench, masseter. And then one important reflex subserved by the fifth nerve is corneal reflex. Ophthalmic division of the trigeminal is the afferent, bilateral seventh nerve is the efferent. So when we touch the cornea with a wisp of cotton on one side, both the eyelids close. That is corneal reflex. So very important, because to evaluate brainstem functions, we take all these reflexes into consideration. Midbrain, we see the size of the pupil. If the pupils are small and reacting to light, that means midbrain is intact. Pons, we check out on the corneal reflex, because the ophthalmic division of the trigeminal nerve, fifth nerve is in the pons, seventh nerves are also in the pons. So the corneal reflex and oculocephalic reflex are intact, that means the pons is intact. And if the person is breathing well, that means the medulla oblongata is intact. So the person is breathing well, corneal reflex is intact, OCR is intact, and pupils are small and reacting to light, that means his brainstem functions are intact. So corneal reflex is very, very important when we examine a person, especially a critical patient. Jaw jerk. Jaw jerk is a deep deep jerk. The afferent is also fifth nerve, the efferent is also fifth nerve. Why is jaw jerk very important? Because it's the only jerk which is subserved by the cranial nerve, fifth nerve. So if there's any lesion, an upper motor neuron type above fifth nerve, that means the jaw jerk will be brisk. So it is mainly useful to differentiate whether it is pseudobulbar palsy or bulbar palsy. If the jaw jerk is brisk, that means it is an upper neuron lesion. The pathology is above the fifth nerve, that is usually above pons. Abducent nerve. Abducent nerve supplies the lateral rectus. So if the abducent nerve is affected, the lateral rectus gets affected. They'll have double vision on looking at far off objects. One important clinical point about abducent nerve is that this cranial nerve, because of the raised intracranial tension, it can go and impinge the sixth cranial nerve on the clivus bone, and therefore the sixth nerve can get affected in a person with raised intracranial tension. This is known as a false localizing sign, because it is not the sixth nerve per se which is affected. It is because of the raised ICT, the pressure is transmitted and the sixth nerve is impinged upon the clivus. So sixth nerve involvement is very common in persons with raised intracranial tension. Sixth nerve is not affected per se though, and it is a false localizing neurological sign. Seventh nerve. When seventh nerve is very, very important, especially when we talk in terms of hemiplegia. So how do we test in the seventh nerve? We ask the person to elevate the eyebrow. We look at the forehead, wrinkling, eye closure, smiling, and cheek puffing. We should always look for the differences in the lower versus upper facial muscles. Upper motor neuron lesion, weakness of lower facial muscles with preservation of upper facial muscles, whereas weakness of the entire side of the face is seen in lower motor neuron lesions. In a hemiplegia, especially in the internal capsule lesion or anything above midbrain, usually the cranial nerves are not affected. We see so many hemiplegic patients. The cranial nerves are not affected. Why the cranial nerves are not affected? Because all the cranial nerves have got bilateral innervation. So even if the one side the corticobulbar fiber is cut off, the other corticobulbar fiber comes and supplies the cranial nerve nuclei, and therefore the cranial nerves are not affected. But there's a catch in seventh nerve. Seventh nerve has got upper part and the lower part. Upper part has got bilateral innervation like all other cranial nerves, but lower part has got innervation only from the opposite side. And therefore when there's an upper motor neuron lesion like left side, person's lower half of the face only gets affected, and that too on the opposite side, and the hemiplegia is also on the opposite side. So weakness of the lower facial muscles with preservation of upper facial muscles, it's an upper motor neuron type. But if it's a Bell's palsy where the final common pathway is cut off, the final pathway is cut off, and therefore both the upper part and the lower part on the same side gets affected, like Bell's palsy where they have difficulty in closing the eyelid. Because there's a difficulty in closing the eyelid, whenever they attempt to close the eyelid, you can see the eyeball moving upwards. This is a normal phenomenon known as Bell's phenomenon, well seen in persons suffering from Bell's palsy, because they cannot close the eyelids, but the moment they attempt to close the eyelids, you can see the eyeball moving upwards. Eighth cranial nerve. Eighth cranial nerve has got two components, vestibular component and cochlear component. Cochlear nerve component is concerned with hearing. So we can make whispered voice and see whether he is able to hear. Rinne's test. The principle is air conduction is better than bone conduction. Obviously, if this conduction defect is there, the bone conduction becomes better than the air conduction. Then we do Weber's test, where we put the frequency vibrating tuning fork 512 hertz on the forehead and see whether the person is able to appreciate it. So in Weber's test, if there is an air conduction, because it is not being able to transmit, it will be better transmitted in the bone. So in Weber's test, if it is a conduction defect, it is lateralized to the deaf ear. Very important point. Then we check out on the vestibular component. Cows, cold opposite, warm same. What is this? The vestibular component, that is eighth nerve, is connected to the third, fourth and sixth nerves through medial longitudinal fasciculus. Imagine right vestibular component. The right vestibular component is connected to the PPR, paramedian pontine reticular formation on the left side. The paramedian pontine reticular formation will pull the eyes towards its side by supplying the lateral rectus on the left side and medial rectus on the right side through the MLF. So if my right vestibular component is stimulated by turning the head to the right or pouring the water, hot water, warm water on the right side, my eyes will move to the opposite side because the opposite PPRF is stimulated. But the frontal eye fields will try to put the eyes back to its normal state, so there will be nystagmus. So when we put warm water, the eyes will go to the opposite side, but the nystagmus will be to the same side. Whereas if we put cold water, it inhibits the vestibular component. Example, on the right side, if I put cold water, it inhibits the vestibular component on the right side. So the left vestibular component will overact, it will pull the eyes towards the opposite side. Now frontal eye fields will try to push the eyes back to its side, so there will be nystagmus. So when we put cold water, the nystagmus will be to the opposite side. When we put warm water, the nystagmus will be to the same side. So this is known as Dawes-eye movement or oculocephalic reflex. We can elicit it at the bedside by turning the head to the opposite side, but we see this in comatose patients, because in normal persons it is up to you to look wherever you want, and the frontal lobe will suppress this reflex. So it is well seen in persons whose conscious levels becomes lowered, and as the conscious levels falls, this reflex becomes manifest. And another important sign we can test is Romberg's sign. The Romberg sign, the balance is because of the three components. One is the vestibular component, second is the eye component, third is the proprioception component. If even one of these three components is lost, person still can balance because the other two components will support. But if two components are lost, person will lose balance and will fall. For example, if a person has got vestibular component being affected, his eyes and posterior column can compensate, still the person is able to balance well. But with vestibular component being affected and he closes his eyes like washing water, sprinkling water when he tries to wash the face, the ocular component is gone, the vestibular component is gone, two components of the three are gone, so he tends to fall. This is known as, this is a history what we get. Romberg sign is ask him to stand with legs close by, hands extended, close the eyes, and the person, if he sways and falls, that means it is Romberg's sign. The 9th and 10th cranial nerves, the glossopharyngeal and vagus nerve, we look at the position and the symmetry of the palate and uvula at rest and ask him to say phonation ah, whether the palate and the uvula are moving well, they are in the center or they are deviated to one side. We check on the gag reflex, it's slightly uncomfortable procedure for the patient. On checking, we see the movement, whether it is symmetrical or not. Cranial nerve examination. 11th nerve, the spinal accessory nerve, we check out on the trapezius, shoulder shrug and sternocleidomastoid. If my sternocleidomastoid on the right is stimulated, my head will turn to the left side. So sternocleidomastoid and trapezius are supplied by the 11th nerve. There is one important catch in the 11th nerve sternocleidomastoid, like 7th nerve. 7th nerve, the upper part has got bilateral innervation, but lower part gets innervation from the opposite side. Sternocleidomastoid is peculiar. It gets most of the innervation from the same side. For example, if the right cortex gets involved, the right sternocleidomastoid is affected. So when the right cortex is involved, person will have left hemiplegia, and since the right sternocleidomastoid is affected, they cannot turn the head to the opposite side. So the head will turn towards the same side of the lesion and hemiplegia is on the opposite side. So this is the explanation for the head being turned to the same side as that of the lesion in a person with stroke, because the predominant supply of the sternocleidomastoid comes from the same side. So if right cortex is involved, right sternocleidomastoid is involved, they cannot turn the head to the opposite side. Head will be turned to the same side as the lesion and hemiplegia will be on the opposite side. 12th now, hypoglossal. Now we inspect the tongue for atrophy or fasciculations because it will suggest the element type, especially motor neuron disease, amyotrophic lateral sclerosis, bulbar palsy. We can see fasciculations, we see atrophy whether it's narrowing, and we see the strength of the tongue, positioning with protrusion and strength when extended against the inner surface of the cheek on each side. We ask the person to put the tongue inside the cheek and then try to push the finger, then we can see the strength of the tongue. So this is in nutshell the cranial nerve examination, very important. So now after the cranial nerve examination, we'll go to the motor examination. Again, as the rule of 4 I said for cranial nerves, let me talk about the motor and sensory, an easy way to remember. All the important tracts which start with M are medially placed. Like corticospinal tract, motor tract is medially placed. Medial longitudinal fasciculus, which connects 3rd, 4th, 6th with 8th, is medially placed. The medial lemniscus, that is posterior column, is medially placed. The motor part of the cranial nerves are medially placed. So all the important tracts which start with the letter M are medially placed. So what are the tracts which start with the letter M? M for M. M it starts and M is medially placed. One is the motor tract, that is the corticospinal tract. Second M is the medial longitudinal fasciculus. Third is the medial lemniscus. Fourth is the motor nuclei of the cranial nerves. So the tracts which starts with the letter M are placed in M, that is medially placed. The tracts which start with the letter S are placed sideways, laterally. So what are the tracts which are placed laterally? One is the sensory part of the cranial nerves, like trigeminal nerve, they are placed laterally. The spinothalamic tract is placed laterally. The spinocerebellar tract, they are also placed laterally, that is sideways. So spinothalamic tract, the sensory part of the cranial nerves, the spinocerebellar tract, they are all placed laterally, sideways. So these are the S, these are the M. So now motor examination, that is corticospinal tracts which are placed medially. Motor examination, it begins with appearance, tone, strength. Appearance, we look for muscle atrophy or fasciculation. If there is muscular atrophy, if there is severe weakness of the muscles, it suggests an element type. UMN type, usually we do not get much wasting. If at all there is wasting, it could be diffuse atrophy. Fasciculations, involuntary twitching of the muscles, it indicates element type. Anterior horncells like poliomyelitis or amyotrophic lateral sclerosis, where the anterior horncells are affected. This is because of Cannon's law of denervation supersensitivity. When the anterior horncells are denervated, it becomes supersensitive to acetylcholine and starts spontaneously and we have the spontaneous contraction of the muscle twitches, which is fasciculations. The tone, it is a resistance offered by muscles to passive movements. It could be rigidity wherein the tone is equal throughout, the resistance is equal throughout, and it affects all groups of muscles equally. Spasticity, the tone is increased, hypertonia, but it is clasp knife. Initially it is difficult to overcome, then it becomes easy to overcome, and then it has got a predilection for anti-gravity muscles, that is flexors of the upper limbs and the extensors of the lower limb. Because the tone is increased in the flexors of the upper limb, they flex the upper limbs, and the tone is increased in the extensors of the lower limb, the tone is increased in the extensors, so they have to encircle and walk. This is the explanation for circumduction gait. Because of spasticity, they have circumduction gait in strokes. Strength, we check upper limbs. The subtle sign, the sign for potential weakness of upper limbs or corticospinal tract is to check on the pronator drift. If there is obvious weakness, that is okay, anybody can pick it up. But if there is only potential weakness or subtle weakness, How do we test it? We test by pronator drift, very important. We ask the person to extend the hands palm upwards and then see if the person has got corticospinal tract involvement, slowly the hand will pronate. So this is known as pronator drift. That means the corticospinal tract is weak, the supinator is weak, so it is overcome by the pronator. This is known as pronator drift. Very, very important. So if we are asked to test for weakness in a person who's got potential weakness, we should always check out on the pronator drift. Then we have to check on the strength of the wrist and finger extensors. In the lower limb, we check on the strength of the flexors and walking on the heels and toes. Walking on the heels means dorsiflexors are intact, L5 is intact. Walking on toes means S1 is intact, that is plantar flexors are intact. Pyramidal weakness is very, very interesting. Corticospinal tract has got predilection for certain muscle groups. In the upper limbs, the extensors are involved and the lower limb flexors are involved. Since the upper limb extensors are weak, they go in for flexion. Since the flexors in the lower limb are weak, they go in for extension because of the increase in the tone. So if we find weakness in the upper limb extensors and lower limb flexors, it is pyramidal weakness. Whereas if it is myopathy, they will be having bilateral proximal weakness. They cannot get up from squatting to the standing position. They have to get up on themselves. This is known as Gover's sign. So if they have bilateral proximal weakness, it is myopathy. If a person has got bilateral distal weakness, that means it is neuropathy. So by just examining, we can get so much of information. Muscle stretch reflex. By muscle stretch reflexes, we can place the lesion. For example, if it is above the particular root, so the reflexes will get exaggerated, upper motor neuron lesion. If that particular root or the anterior horn cell gets affected, that means the reflex will be absent, it is LMN. So if the reflexes are exaggerated, it is UMN. If the reflexes are absent, it is LMN. So by knowing this basic principle and eliciting reflexes, we can place the lesion. For example, if the biceps is involved, biceps jerk will be absent. That is C5 will be absent. If the brachioradialis is involved, C6 will be absent. If triceps is involved, C7 is absent. For example, if a person has got a C7 lesion, what happens? C7 lesion. So C5, C6 are intact. So biceps and brachioradialis are intact. C7 is affected. So triceps jerk will be absent. What happens to the finger flexors, patellar and Achilles? They get exaggerated because the C7 is affected. So the corticospinal tract is affected at the level of C7. So for C8, T1, L3, L4, S1, S2, it becomes upper motor neuron. So above the lesion, the reflexes are normal. At the level of the lesion, it is LMN type. Below the lesion, it is UMN type. By knowing this basic concept and by eliciting the reflexes, we can place the lesion. So what is the root value for biceps? It is C5. For brachioradialis, it is C6. For triceps, it is C7. For finger flexors, it is C8 and T1. For patellar, it is L3, L4. For Achilles reflex or ankle reflex is S1, S2. Cutaneous reflexes, the very important reflexes, the Babinski sign or the plantar response. Generally, when we come from the lateral surface of the toe and come medially, all the toes go for flexion. This is a normal response. But if a person has a corticospinal tract lesion, when we try to elicit the plantar response, the big toe goes up and the other toe goes for fanning. This is known as Babinski sign. So if this person has got Babinski sign, that means person has got upper motor neuron lesion above S1. The other cutaneous reflex is the abdominal reflex, and if a person has got lesion at T10 and below, the lower abdominal reflexes will be absent, but the abdominal cutaneous reflexes will be present. In fact, one important sign is Beaver's sign. If a person is asked to get up from lying to sitting position, the lesion is at T10 and below, the lower abdominal muscles cannot contract, but the upper abdominal muscles above T10 is intact, so they draw the umbilicus upwards. So this is known as Beaver's sign. By looking at it, we can place the lesion. The other cutaneous lesions are cremasteric reflex, bulbocavernous reflexes. Primitive reflexes. What are primitive reflexes? These are the reflexes which are present in our infancy. These are normal reflexes which are present in infancy, but as the brain matures, like especially frontal lobe and parietal lobe matures, these reflexes become diminished and absent. For example, rooting reflex. When we place finger on the middle of the lips, they try to suck it, they try to pout, or sucking reflex. When you come into the angle of the mouth, they try to again go towards the finger. Grasping, they try to hold on. Avoiding, they try to avoid. All these reflexes are normal reflexes present in infancy, but as the brain matures, frontal lobe and parietal lobe, by 1 year and above, these reflexes should diminish. That means the brain has matured. If these reflexes do not diminish, that means the brain has not matured. Or once these reflexes are absent after 1 year and then they reappear, say after 40 to 50 years, that means the frontal parietal lobe, which have matured well, now they are going for degeneration or atrophy. So such important information we get by looking at the primitive reflex, namely the rooting reflex, sucking reflex, grasp reflex, and avoiding reflex. These reflexes are present normally in infancy, but they have to disappear after infancy. If these reflexes are present beyond infancy or disappear and reappear after some time, that means the lobes are immature or diseased. Then we come to the sensory system. The two important tracts are the spinothalamic tract and the posterior column. Spinothalamic tract carries pain and temperature, and the posterior column carries the vibration, joint position sense, and light touch. So the 5 primary sensory modalities which you have to test is light touch by wisp of cotton, pain by pinprick, temperature, putting hot water or cold water in tubes, asking him to feel, vibration by tuning fork 128 Hz, keeping on the bones and asking him whether he is able to feel. Joint position sense, we hold on the big toe on the lateral side and move upwards and downwards. The person closing the eye should be able to tell whether the toe has gone upwards or downwards. So these are the 5 primary sensations we need to test. These are perceived till the level of thalamus, from the receptors till the level of the thalamus. The sensations which is perceived from the thalamus to the parietal cortex are known as the cortical sensations. So obviously the primary sensations are intact and the cortical sensations are absent, that means the parietal cortex is affected. So cortical sensations, these are mediated by the parietal lobe and represents an integration of the primary sensory modalities. Testing cortical sensations is only meaningful when primary sensations is intact. The cortical sensations are tactile localization. They should be able to precisely tell where the point is made. 2-point discrimination. 2 points should be felt separately. In fact, the 2 points which are felt separately and very sensitive are the lips, where even a small distance can be felt as 2 different points, and fingertips, because fingertips and lips has got a larger representation in the brain, the sensory homunculus. So 2-point discrimination is highest, very sensitive in the lips and the fingertips. So tactile localization, 2-point discrimination, graphesthesia, we draw a number on a person and closing the eyes, he should be able to tell what number has been drawn. Stereognosis, we give a bunch of keys, place it in hands. With closing the eyes, he should be able to tell it is bunch of keys. So stereognosis, graphesthesia, barognosis, seeing the weight, tactile localization, 2-point discrimination, and simultaneous stimulation. We simultaneously stimulate 2 points and see whether he is able to appreciate the 2 points. If he's got right parietal lobe lesion, he may neglect on the left side. So as the pronator drift is important to test the subtle nature of weakness or subtle nature of the corticospinal tract, the stereognosis is sensitive to pick up the sensations or sensory loss, the subtle sensory loss, the subtle impairment of sensory tract, because stereognosis, feeling with closed eyes, the texture needs integration of lot of primary sensations. So if one sensation which you need to test and to find out whether the sensory parts are intact or not, we should always check out on the stereognosis. And one test which we need to know whether there is a subtle weakness is the pronator drift. These are very, very important clinical points. Coordination, the rapid alternating movements of the hands and fingers. When agonist contract, antagonists have to relax. For example, lifting the dumbbells. When I have to lift the dumbbells, the agonist contract, biceps contract, but the trigonists have to relax. This is known as Sherrington's law of reciprocal innervation. If this happens only, then we can perform our activities normally. So normally when agonist contract, antagonist relax. This is known as Sherrington's law of reciprocal innervation. But this may not happen physiologically in 2 conditions, like standing and shivering, where both agonist and antagonist contact. Other than these 2 conditions, if agonist and antagonist contact together, it is known as co-contraction of agonist and antagonist, resulting in all kinds of awkward posture known as dystonia. So when again the cerebellum is very important in immediately switching the agonist and antagonist and again agonistic movement. So if cerebellum is involved, we cannot immediately switch over the agonist and antagonist like rapidly alternating movements of the hand. This is known as dysdiadochokinesia. So ask the person to rapidly alternate the hand movements. If he is able to do it, that means his cerebellum is intact. If he is not able to do it, that means his cerebellum is affected. Then ask him to touch the finger to the nose. So finger to nose, he may come near, but he may not be able to absolutely touch the tip of the nose, because for gross movements corticospinal tract is sufficient, but for the fine delicate movement like putting the button in the buttonhole or touching the nose with the finger, we need cerebellum and the basal ganglia. If they are affected, then we cannot. And then finally the gait. If the corticospinal tract is affected, they'll have circumduction gait. As I said, the flexors of the upper limb, the extensors of the lower limb, there is increased tone. If there's a short stepping gait, we have to think of Parkinson's disease. If there's a broad based gait, we have to think of ataxia. If there's scissoring gait, if the corticospinal tract bilaterally are affected, both the adductors group get affected, so they'll have spasticity. They walk like scissors. High stepping gait, peripheral nerve, common perineal nerve involvement, so they cannot dorsiflexolus. So to clear off the ground, they have to take high steps and walk. Posterior column, they cannot feel the hardness of the voice, so they have to stamp and feel the hardness of the floor. It is known as stamping gait. And if the frontal lobe gets affected, they get magnetic gait, that is, they get stuck, and because of the apraxia of the frontal lobe disease. So finally, neurologic diagnosis, always remember the uncommon manifestations of common diseases are more common than the common manifestations of uncommon disease. So history and neural examination has to be integrated to make out the diagnosis, and we should always try to diagnose the common diseases. So how does this history and examination help in localization? So it could be in the cerebrum, it could be in the brainstem, or lower down in the neuraxis. So how do we localize it? If the cerebral cortex is involved, there will be abnormal mental status or cognitive impairment. They will have seizures. They will have weakness and sensory abnormalities on the opposite side, because the corticospinal tract has crossed, posterior column has crossed, spinothalamic tract is crossed. So they will have manifestations on the opposite side. They will have visual field abnormalities, homonymous hemianopia, because the optic radiations get affected. The cerebrum gets affected. They will have movement disorders because basal ganglia can get involved, like tremor, chorea, caudate nucleus is involved. If it is brainstem, there will be ipsilateral cranial nerve palsy, 3rd and 4th in midbrain, 5, 6, 7, 8 in the pons, 9, 10, 11, 12 in the medulla oblongata, and they will have contralateral weakness or sensory disturbances. If it is in the spinal cord, they will have back pain or tenderness. They will have weakness and sensory abnormalities below the level of the lesion, sparing the head. They will have mixed upper motor neuron signs and lower motor neuron signs, because the anterior horn cells at the level get affected. The corticospinal gets affected below the level of the lesion. They will have a sensory level, and they will have bladder disturbances, bowel disturbances, and sexual disturbances, sphincter dysfunction. If it is spinal roots, there will be radiating limb pain. There will be weakness or sensory abnormalities following root distribution. There will be loss of reflexes. For example, if C5 is involved, biceps is lost. If it is peripheral nerve, the mid or distal limb pain gets affected. Peripheral neuropathy, axonal neuropathy is a length dependent neuropathy. So the distal parts get affected more. So the pain is more in the distal area. The weakness and sensory abnormalities, they follow nerve distribution. They are more in the distal areas. Stocking, that is the socks or the glove that is on the hand. The distribution of the sensory loss is more in the hands and the socks, the legs of the socks. And one important point is that as the weakness and the sensory disturbance reach the level of the knee, the hand should get affected, because it's a length dependent neuropathy. There could be loss of reflexes also. If it is a neuromuscular junction like myasthenia gravis, they'll have bilateral weakness, including phases, ptosis, diplopia, dysphagia, and proximal limbs. One important point of neuromuscular junction myasthenia gravis is that it's a neuromuscular junction of the skeletal muscle. So smooth muscle gets spared. So pupil will be always intact in myasthenia gravis. And easy fatigability, there's increased weakness with exertion. Morning they'll be normal, but after some time they'll have weakness. For example, if they're asked to chew chicken, initially they'll be able to chew chicken well, but after some time there's fatigability and they find difficult to chew the chicken. and sensations are absolutely intact because it's a neuromuscular junction disorder. If it is muscle, as I said, the bilateral proximal muscle weakness is present, and they have difficulty in getting up from squatting to the standing position. They have to climb on themselves. It is known as Gover's sign, which is characteristically seen in Duchenne's muscular atrophy, and again the sensation is spared. So if we go systematically, the examination, general physical examination relevant to neurological examination and neurological examination, we can, with the help of investigation, diagnose the neurological disease with ease. That is the joy of clinical neurology. I hope you have enjoyed listening to my lecture as much as I have enjoyed delivering it. If you have any suggestions or comments, kindly post on to my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.